what I do, this is a personal preference. Alright? You can get a sharp tip with this. And soft, you want a better one, you not so good. Sharp tip or the pin, then you just have to assess. Okay. Selamat tengah hari cik, saya Dr. Regu. Ni anak buah saya. So, kita nak buat check sikit. Boleh? Boleh. Okay. He can either be lying down or sitting up, whatever you prefer. So don't never forget always introduction and which side of the patient am I?
Right side.
Right side. Important. And whenever you have an exam, alright, this is a general tip is once you have done this, when somebody is giving you an instruction and you are panicking, don't know what to do, always just take one walk to the side of the bed and then just have a look, smile a bit. You don't. The lecturer thinks you are confident, but you are thinking, what am I going to do next? This is all. You know, as you go through clinical practice, you will learn. All right. So we are going to assess sensation. So I'm going to cut to the chase. Once you have introduced him, ideally when you're doing a sensory examination, you will start with the upper limbs first. Ideally, cik, cuba buka baju atas ni, boleh? Okay. Sensory. By ideal, you should see this. I like to expose the patient adequately. Alright? Okay. And if you are in the ward setting, draw the curtain a little bit in the ward setting. Simply because, you know, there are so many patients there, there are relatives there. Okay. So start the examination by saying, okay, saya akan cakap sikit boleh adik? So this is a young Malay gentleman. He is seated comfortably on the bed. Right? There is no abnormal habitus of his limbs. Tengok jari. Okay. There's no obvious ulcers or scars because see, you're doing sensory examination, your brain will be looking for ulcers, any obvious deformity. No. Come to the back, have a quick look. Any obvious scars, any injuries. You know, if you have a brachial plexus injury, for example, you may have a scar. So your mind is automatically working on all these things. Okay. So now you go on for the sensory modality. Okay, I'll use the pin since they provided a lot of effort to provide the pin. Okay. Nak periksa deri rasa sakit. Jangan takut saya akan tekan kuat. Okay. Important thing, explain what you're going to do to the patient. Second thing, okay. Tutup mata. Don't forget this. Ask him to close his eyes. Okay. Boleh rasa ni. Rasa apa? Tajam, sakit. Okay. Belah ni? Sama ke dua-dua belah? Okay. So this is your testing your baseline. They say now I want to examine the upper limbs. So I'm testing the baseline first. Similar, because you want to have something to compare with. Okay. Then you proceed on. Okay, tutup mata. Okay. Boleh rasa ni? Rasa? Okay. Tajam. Okay. Now with the upper limb, you can generally approach it from a dermatomal perspective. If you remember the dermatomes, C5 is your regimental badge area. C6, C7 is your favorite center finger. C8 is the smaller less fingers, T1 and T2. So what we do is, okay, just say there's an abnormal side. In this case, it's a normal patient, but abnormal side, which side should you examine first?
Normal.
Normal side first. Don't forget. Sometimes when we are panicking, we will always go and check the wrong side first. Okay, right. Okay. Boleh rasa ni? Rasa apa? Okay, sama dengan ni. Ni? Dua-dua belah sama. You must go through this process. Some people will do this. Rasa ke? What is the advantage or the disadvantage? There's the difference between an entry-level clinician and somebody who has been practicing medicine for a long time. Why? Because, as I told you, nothing is always black and white. It's never none and absent. No. There can be grays. He may be able to feel, but it's not as strong as the other side. That's why the baseline is very important. And you have to compare one with the baseline and with the opposite side to get a good representation. So same thing. Okay. Sama. Belah ni. Boleh rasa ke? Rasa? Dua-dua belah sama. Apa yang dirasa? Okay. Sama dengan ni? Okay. So C5, C6 ni dengan ini apa yang dirasa? Sama ke? So C6 sama dengan ni. Okey. Ini dengan ni sama. Ini dengan ni sama dengan ni. Okey. Ini dengan ini sama. Okey. So dua-dua belah sama. So you see, very quickly you can do a pain. By right you can start with the light touch, but I'm going straight to pain because what do you call it? that's the one that, the principles are the same. Pain, light touch. We are not going to cover temperature in this thing because sometimes you have to get the exactly calibrated, container with the ice and the heat, hot water. So mainly, similarly, with the fine touch, you use a cotton ball. Exactly what I did, but different instrument, right? So fine touch, pain. What's the next thing? Temperature. Okay, I already mentioned.
Vibration.
Vibration. Okay. Before that, which is easier to test?
Proprioception.
Proprioception. I'll tell you, in clinical practice, the ones we do first are the ones we can test well. Okay. Check. Okay. Okay. Buka mata. Okay. You must hold the thumb like this, not like this, right? Isolate the joint. Okay. Ini atas, ini bawah. Okay. Faham? Ini atas, bawah. Make sure you clearly show him and explain to him. Okay. Tutup mata. Atas ke bawah? Atas ke bawah?
Bawah.
Atas ke bawah?
Bawah.
Okay. Atas ke bawah?
Atas.
Okay. You must also look for how fast he answers. And if he's not sure, see, if your proprioceptive function is intact, there will be no doubt, immediately you can do it. Alright? Similarly, atas ke bawah?
Atas.
Atas ke bawah? Tutup mata. Okay. Atas ke bawah?
Bawah.
Atas ke bawah?
Atas.
So his proprioception is fairly intact. Okay. Usually we just have to test the thumb, and if you are doing the lower limb, we check the
Big toe.
the big toe. Alright. Okay. So sensory examination of upper limb, I have shown you. I've shown you pain and I've shown you proprioception. Vibration can be tested. Where's the hertz? Is this the 256? Usually what 256 is not appropriate. You should use 128. Because till for tomorrow you will be testing because it's not strong enough. Not okay. Boleh rasa ni. Okay. Boleh rasa ni. Ni dengan ni sama. Ni dengan ni sama. Okay. Vibration is a little bit harder to quantify because there's a lot of issues with regards to when you strike the tuning fork, or not. It may seem louder, so that's why you have to keep tuning and keep comparing. So the things, pain, temperature, and pain and touch particularly is the one you can really map out. Vibration is a bonus. Similarly, proprioception is more objective compared to vibration, but nevertheless you test it. Similarly, you compare over common bony landmarks. So you can even use the ni sama, and then compare to the sternum, right, or the forehead. Okay. So now I've just given you a rough idea of how to do it. We will do the same, repeat the same thing on the lower limb, but we try to do everything. Okay. Because why I'm rushing for time is I want to give you all an opportunity to examine. Because you always thought, and we never stop teaching you. When we never give you opportunity to do things. Okay. We still have time. It's only 4. Okay. Any volunteers to do the lower limb examination? Don't worry. It's not an exam. I will definitely interrupt you and kacau you, but the hope of making you better. Don't be shy. Come on, anybody, just come forward. No problem. Don't worry. If you cannot remember the sequence, I will teach you what to do. Come. Come. That's the way, man. Okay, dek. Cuba baring sekejap. Okay, baring ha. First, remember, first rule of anything, say hello. Good dream. Explain who you are.
Boleh panggil saya Hong kan? Nama kamu apa? Faizuddin. Oh, nama sama dengan kawan saya.
So now you're on the right side of the patient. Okay, now will be a teaching session lah, alright? Right side. Okay, so exposure. So in order for you to perform your examination, you say, I'd like to expose the patient completely. However, to care for his modesty or in consideration for his modesty, I will expose him till the level of the mid thigh. Okay. Kita nak buka baju sikit sampai kaki ya. Sekejap. Okay. Pegang ni. Okay. Boleh ya? No problem ah. Okay. So you see, if you have been to the ward enough, you know how to do this. The lecturer knows whether you have handled patient before or not. Because this is an easy way to cover up. If not, you hold one leg, there will be one opening here. You know, and the patient feels in control because they get to hold. You understand? It's very important. I tell you, you must imagine yourself in that position.
Yeah.
And, there are so many unknown people, whether doctor or not, medical student or not. Right? So these are all some tricks. Okay. So, all right. Take a walk to the bed. Take a bed. Okay. So give us a little bit of commentary. What do you see?
Okay, there is no any deformity.
Before that, this is a young.
This is a young boy.
Okay, good.
This is a young boy. Then,
Is it comfortable, uncomfortable in any distress?
comfortable lying on the bed.
Very good. Okay, correct. Comfortable on the bed. Okay. Now you go on to the limbs. Any obvious deformity?
No obvious deformities.
Okay. Any ulcer, injury?
No ulcer. Got injury.
What is this?
This one, this
Huh?
got scar.
Okay. If you're not sure, don't commit to what it is. This is a person's scar overlying his right knee. And when looking for ulcers, you make sure you always come and look at the bottom because a lot of the ulcers, pressure ulcers can be here. You know, it's okay to look like that. You know, sometimes even intratriginous spaces. You know, this is later on in your life when you are doing a sensory examination, you shouldn't forget all this. Sometimes they want to repeat the sequence, but forget to look. Okay, good. Okay, then.
Okay. And I explained to him what I need to do.
Okay, good. So we'll start with the sensory examination for light touch.
Like that.
Yes. What are you supposed to use for light touch?
Cotton.
Cotton. Great.
Sekarang saya nak guna kapas ini untuk sentuh sedikit saja. Kalau ada rasa bagi kau saja. Then the light touch is according to the.
Okay, good. So first you must test your baseline. Remember what I told you? Okay. So either forehead or sternum. Go ahead. Tutup mata. First, apa dia rasa? Don't. He's very brave and trying to do for the first time. We should encourage him. Okay. Tutup mata.
Rasa dah. Rasa. Okay.
So ask him, can feel. Okay, go on.
Then
Okay, before that, you're going to do dermatome, right? So, just to recap, what are the dermatomes?
lumbar and sacrum.
Okay, very good. So, what are they? If you cannot remember, don't worry. You just tell me, then I'll teach you.
Then L1, L2, L3, L4, L5.
L1 is higher up, alright? L1, L2, L3, L4, L5. You step on S1. S2, S3, S4. Usually S2, S3, S4. You can test. So remember L1, L2, L3, L4, S5, L5, S1. This is minimum you must do. Alright? Okay, so go ahead. Start with L1.
L1.
Ask him to close his eyes.
Sorry. Pejam mata. Okay. Rasa tak? Rasa sama dengan ini tak? Rasa, okay. Then, ini dengan ini sama rasa tak?
Good. Okay, keep going.
Then, rasa tak? Sama dengan ini tak rasa? Okay. Kedua-dua belah sama rasa tak? Okay, good. Ini rasa tak? Sama dengan ini. Kedua-dua ni sama rasa tak? Okay. Rasa tak?
你说什么？
Sama dengan ini tak? Ini dua ni dah sama rasa tak? Okay. Sama rasa tak? Sama dengan ini tak? Kedua-dua ini sama tak?
Okay, good.
Okay, then continue.
Yes, S1, the soul. So, that picture, do you have a picture of dermatome in your image, in your notes? It's there, right?
Yeah, that's wise.
So things after some time, if you regularly practice, then you will be able to remember already. Huh? Okay.
Okay. Ini ada rasa tak? Ada. Sama dengan ini tak? Sama. Okay. Kedua-dua ini sama tak? Sama.
Okay. Now pinpoint. There's a pin there. The cotton ball you use one?
No.
Don't recycle.
Encik buka mata sekejap. Saya sekarang nak cucuk ini tapi saya akan tak akan cucuk dah lama, so tak perlu takut dulu. Okey, sekarang pejam mata. Rasa tak? Sakit tak? Sakit oh. Rasa tak? Sama tak? Kedua-dua ini sama tak?
Sometimes you want to try, you can put a few times. It doesn't have to be just one touch. But don't put too much force because then it becomes fleshy.
Rasa tak? Sama dengan ini tak? Sama. Okay. Kedua-dua.
That's L. 2. Okay, good.
This one pula. Kedua-dua ni sama rasa tak? Okay. Rasa tak? Sama seperti tadi tak? Kedua-dua ini sama rasa tak? Okey. Rasa tak? Okey. Sama dengan ini. Okey. Kedua-dua ini sama rasa tak? Okey. Kalau doctor here is L5.
No, that's L4.
L4 then L5.
The lateral aspect of the foot here is L5. The sole is S1.
Rasa tak? Rasa sama dengan ini. Okey. Kedua-dua belah ini sama rasa tak? Okey. Rasa tak? Okey. Sama dengan ini. Kedua-dua belah ini sama rasa tak?
Doctor, I got a question.
Sure.
For every dermatome, we should compare with the reference point.
Yes.
Oh, for
Yes.
every.
Because it depends what. You may not have to compare every single time. Maybe every 2 dermatome you just quickly go back to remind the person. Because sometimes when you are examining, imagine yourself also, same. You yourself will forget, you know. So that's why we keep comparing to delineate out. Okay. Last, vibration. Proprioception. How do you do proprioception?
Perception is Encik sekarang saya nak
Okay.
Like
Now
that.
what do you do? Okay, first. Kejap. Relax. Okay. Okay. Ni atas. Hold the side tu. Ini bawah. Okay. Tutup mata. Separate the throat. So there's no cutaneous. When you're doing this, you can feel on the skin. Separate the joint. Hold it. Atas ke bawah. Atas ke bawah. Atas ke bawah. Atas ke bawah. Okay. So it's hold, separate, hold at the side, not like this. No, not like this. Like this. And you ask. Atas ke bawah. Sekarang. Similarly. Atas ke bawah. Atas ke bawah. Atas ke bawah. Atas ke bawah. So you see, same thing. Okay, so for proprioception, vibration, similarly you can compare on this and the malleolus. You want to try? You can do this, or you can do this if you are takut for your bones. Sometimes they hit on the table or don't do that. Ambient sound. Okay.
Sekarang saya ketuk sini saya rasa. Pejam mata.
好妙啊 Oops
Boleh rasa getaran tak? Boleh rasa tak? Boleh ya? Boleh rasa getaran tak? Kedua-dua sama tak? Sama.
Compare.
Getaran itu sama
You
ada.
use this. I'm concerned that you will get some injury in your elbow joint. Put here. So that's vibrating. Yeah.
Rasa tak? Sama dengan ini tak? Kedua-dua ini sama tak? Sama.
So, So you see how fast you can do a sensory examination? Okay. Then any questions so far?
Doctor, for the vibrational sensors, do we need to say like, tell me when it stops? Like that?
You can take it all the way there, but grossly you can assess when it's intact. If you really want to compare in detail, you can. But the main thing is pain, temperature, proprioception. This is commonly what we do in clinical practice. You can wait till you stop and then you can compare on yourself. But this is a bit subjective. Okay. Now whatever I've shown you is to examine according to dermatomes. But you find in clinical practice now everything will follow a dermatomal pattern of sensory loss. I don't know. Okay. Depending on where the pathology is, we have varying patterns of sensory loss. Okay. If you have a lesion in your cerebral cortex, I don't know, you will usually have a hemisensory pattern of loss on the contralateral side, because we know of the spinothalamic crest eventually will cross. Whether it crosses proximally or distally is secondary, but it crosses. Okay. So when you've done this examination, you can usually map out already a sensory loss. If it's only half, then you are more towards hemisensory loss. Now, just say the pathology is like in the spinal cord. Now, spinal cord lesion, sometimes depending on the level, will have varying degrees of sensory loss. If it is in the cervical spine, if it is above C6, how do you differentiate whether it's above C6 or below C6? Anybody? Anyone? Okay. What does the innervation to the upper limb come from? Which plexus?
Brachial plexus.
Brachial plexus. What is the root value of the brachial plexus?
G7.
7, T8, T1, T2 right now. If there's a pathology at that below that level, below T2, you will have no involvement of the upper limb. Correct or not? If the lesion is either at that level or above it, you will have sensory loss involving the upper limb. True or not? So that's one of the things. Is there sensory loss in the hands or only in the legs? And another thing you can do is, you can look for what is known as a sensory level. Just say the hands are preserved. You want to know roughly what level in the spinal cord it corresponds to. So you use a pin, right? And you can trace out. This is not a good quality. Okay. Where's the pin just now?
Orange color.
Okay. Sorry. To the mother. So please. Boleh rasa? You trace it like this slowly. Boleh rasa? Boleh rasa? Boleh rasa? If there's an abnormality particularly, you trace it proximally to see where it suddenly becomes normal, right? Then you can define your level, and this extends all the way across the abdomen until you get the level. So, because based on based on anatomical landmarks, we can roughly delineate what the level is. Like the umbilicus corresponds to a T10 spine lesion, 10 thoracic level. The nipple line corresponds to T4. I don't know. So these are all gross. The grip cage is around T6. So you see, as you are tracing, you can actually determine roughly where the sensory level is. As this is particularly with regards to spinal cord lesion. So you see, you have to adjust the further assessment according to what you think most likely the pathology is based on examination. But as a general rule, do not forget to compare. You must compare. And the difficulty or the problem with sensory examination is that it is sometimes very subjective. Patients, feel less, more. It's all very, can be a bit vague. So we always combine the information we get from the sensory examination with the motor and the other examination to formulate our diagnosis. So don't forget to compare, get the patient to close the eyes, follow in a systematic dermatomal pattern. Right. Are we okay so far? Anybody else wants to practice? This is a very rapid and quick examination, but you must remember how to do it. Anybody else? Any volunteer?
I got one more question.
Yes, please.
And then for the vibration, so we should test for distal part. Then if the distal part there's no problem, then
As I mentioned, you start with the ankle, the bony landmarks, because you don't test on everywhere. You test on the medial malleolus, you test on the ankle. Similarly, you can test here. You can come out with the elbow. If you really want shoulder, but we very rarely do it,
if the patient can feel, then should we continue or just stop?
To be very honest, you're unlikely to have loss of vibration in the sun without the loss there. So I think for me, you can, if it's intact, you don't have to really go so proximal.
Okay.
See, that examination sequence is a very complete examination sequence. So sometimes in clinical practice, the pain, the touch, that one you got to get it right. The proprioception, you got to get it right. Alright? Good. Who's next? No volunteers.
Doctor, do we
Yeah.
need to proceed with the Romberg's test?
Okay, Romberg's test, you can do it in this setting or you can do it when you're doing a cerebral examination. For me, if you ask me, I know it's listed there. That book has some further editing required by me. I will admit the lecturer who did that chapter has not written the last part. But basically, Romberg's test is a test to assess, to differentiate between ataxia due to sensory sources and cerebellar sources. Okay, do you all know what is ataxia? Ataxia is a sensation of imbalance, unbalanced. Right? So a person with ataxia will manifest with a wide base gait. Right? They will walk like this. Legs are, because you need to stabilize yourself. Right? You have a wide base. This can be a sign of disorder either in the sensory system or the cerebellar system. When I say sensory, specifically proprioception, joint position sense. In order to maintain balance, we need input of joint position sense to be sent to the brain. You need vestibular input from your middle ear. You need visual input from your vision. So what happens is, if you have a sensory ataxia, in a Romberg's test, you ask the patient to stand with their feet together, right now, looking straight. Sometimes you can ask them to stick out the arms if you like, and you observe first with their eyes open whether they have any ataxia, meaning they feel like falling towards that. Then you ask them to close their eyes. If the ataxia or imbalance becomes worse, that is a sign of
Sensory.
sensory ataxia. Why?
Vision.
Because you have lost your modality of vision, which helps you compensate. So you cannot see, plus you cannot feel, you become more imbalanced. If you have a cerebellar pathology,
It's the same.
it doesn't change. Meaning to say, if your eyes are open or closed, you will still be imbalanced. It doesn't get worse by eye closure. So when a person's imbalance or ataxia becomes worse, it's aggravated by eye closure. This phenomenon is known as Romberg's positive. Right? So Romberg's test is a test to differentiate between cerebellar and sensory ataxia. Romberg's positive means when you close your eyes, your ataxia becomes worse and is a sign of sensory ataxia. Cerebellar ataxia does not worsen with eye closure. Alright? Next question. No questions. Anything else about examination? Or anything about anything with regards to the nervous system? Are you able to follow what's written in that book? Is it easy to read?
No.
No.
It's very like jump here and there.
Agreed. Because there are 4 different brains and all 4 brains working differently. So I agree with you. We will wheel them in and change it a little bit more. Alright? Any other things? Any questions? There's still some time for you to examine with the patient. If anybody wants to try upper limbs. What about face? Although it's covered in cranial nerve examination. Yes. 2-point discrimination. Okay. Now, 2-point discrimination and things like determining number written on your hand, all is assessment of higher mental function. If somebody instructs you to examine the sensory system, it is not required, and it will be removed from the text soon. Okay. The reason is because if you ask me, when you ask to do sensory examination, you are focusing on the sensory receptor and the tracts. Higher cortical function, you can have an absolutely normal sensory system, but you can have problems with 2-point discrimination. If you have all read about abnormalities of higher mental function, it's a bit too much for you all to tell you. Basically, when you have a problem in your brain, meaning when I say brain, the sensory cortex, right? You will be able to feel. You can feel, but you cannot make sense of the sensory stimulus. Okay. This condition is known as agnosia. Agnosia is the inability to make sense of sensory input despite your sensory pathway being intact. Alright? Common types of agnosia, something called astereognosia. A means cannot, stereo is touch. So, if you put something in the patient's hand, they can feel it. For example, like a coin or a key, but they cannot recognize it because the area in the sensory cortex which processes the information is not functional. It's a bit different from motor. When you have a motor cortex problem, you have weakness. But sensory is not like that. Sensory, you can still feel, but you cannot make sense of it. Another type of condition where you cannot make sense is A, graph aesthesia. A means cannot, graph means writing, aesthesia is feel. So if you write usually number on the palm, they cannot recognize. They can feel, the I can feel you're doing something, but they cannot recognize the number. These are the simplest type of higher mental function disorder. Similarly, 2-point discrimination, differentiating between 2 points, is a higher mental function, and it will vary according to which part of the body you're dealing with. I don't think you need to include that in your sensory examination. Pain, temperature, vibration, proprioception. These are the most important, comparing with baseline. That is your take-home message. Don't remember the dermatomes. You must follow a systematic way. You must compare both sides. You must adequately expose the patient. Right? Like see, you have pathology. You just say you find weak, sensory loss in the upper limbs and lower limbs. You should also examine the abdomen, in a ascending way to determine. Alright?
So, doctor, we cannot follow the guidebook given to us.
We will make some further changes. I think the last part, the 2-point discrimination, will be removed. But the rest of it is fairly the same.
And also to feel what is the object that one.
We are removing that. Somehow there's been a little bit of incongruity in what they are putting out. So I realized this earlier today. It will be changed. Don't worry.